Hello, doctors, please. How are you doing today? And please let me know in the comment section whether you can hear my voice. Please, can you hear me? Can you hear me? If you can hear me, let me know, please. If you can hear me, let me know. I want to know, can you hear me in the comment section? Please, please, can you hear me? Can you hear me? Doctors, can you hear me? Good. Dr. Bironke says, happy Sunday, Dr. Brony. Please, can you hear me? Beautiful. Dr. Khadija says, yes. We can hear you. Beautiful. Please. Secondly, I have a question. Can you see my screen? Can you see what is posted on the screen? Please, can you see it? Can you see it? If you can, let me know. If you can't see it, let me know. Can you see me? Can you see what is there? Okay, beautiful. So Dr. Mutombo says he can see. We have a deep dive today, and then tonight as well, we have a class with Dr. Nana, and I don't want anyone to miss that class, I don't want anybody to miss that class. So we'll finish today, this class, and then we'll go to Dr. Nana's class. I think it's at, let me make sure I know exactly the time. So Dr. Nana's class today is psychiatry. Oh, so that means, we are getting into psychiatry mode, right? So it's at 6:30 p.m. EST today, okay? And it's already 12, I think it's already 6 p.m. EST. So it's going to be a back-to-back class. So you're going to do this class, and then 6:30 p.m. EST, you're going to jump into psychiatry with Dr. Nana again. It's going to be awesome. And you guys, I know you also like to go for Dr. Nana's class. And then don't forget that after that, in February, we'll be doing 2 more classes in psychiatry to cover everything again. So I'm really excited. So let's jump in. So that you can finish up early and go. Please make sure. Dr. Bironka says, I'm so excited. Yeah. So look, please make sure you are sharing this with your friends. Please make sure you are sharing this with your friends. Don't be greedy. Share the good news of MedCognito with your friends. Send the link of the YouTube to your friends right now. And those on YouTube, please go to our portal and click on the subscribe button. And please click on the like button as well. Today is going to be back to back. After this psychiatry class, let's go. So because of that, I'm not going to waste your time. The rationale for this is that menopause is defined as 12 months of amenorrhea after the final menstrual period, and it reflects complete or near complete cessation of ovarian function. So whenever you see somebody who has menopause, think about complete or near complete cessation of ovarian function, okay? And promotion of health maintenance in this group of women will enhance physical, emotional, and sexual quality of life. Now, what are the causal conditions? This objective relates solely to physiologic menopause, okay? So this particular objective, it relates solely to physiologic menopause. Doctors, please don't forget to click on the like and the subscribe button on Facebook and YouTube. And please go to our YouTube channel. There's so much there. Click on it, make sure so that whenever, click on the notification bell, that bell there, so that whenever we go live, boom. In fact, nowadays I'll start going live even beyond Sundays, okay? We'll be doing other live classes on Nakoski and other things beyond Sundays. So just click on the subscribe button so that as soon as I go live, you'll be notified and then you can join. All right? Okay, good. So what are the key objectives here? If you are giving a patient with physiologic menopause, all right, the candidate will be able to explain and prevent the undesirable effects of menopause. Okay. And the enabling objectives are giving a patient with physiologic menopause, the candidate will, number one, list and interpret relevant clinical findings, including an appropriate history and physical exam. In particular, looking for atypical findings or risk factors for complications of menopause, right? So today, I'll be hitting on this enabling objective very, very well. This particular enabling objective, I'll be hitting on it very well, all right? and list and interpret investigations, including those required for well woman examination. I will not touch on this particular second objective, but I'll be hitting more on this first objective very, very well for you. Okay, now construct an effective initial management plan, including counseling and education of the patient on the normal changes during menopause, exploration of and reassurance about psychosocial concerns regarding aging and sexuality, counseling and education of the patient regarding prevention of osteoporosis and cardiovascular disease, discussing risk, benefits, guidelines for hormone replacement therapy, including topical estrogen therapy, and discussing alternatives to estrogen therapy for some of the symptoms of menopause. Those in MedCognito, if you go to your gynecology portal, you realize that we've done a whole work on menopause there for you. And it goes through all these things. Today's class may not cover everything, but we're going to cover on critical things you cannot miss for the exam. Okay, good. So, as we do, and you guys told me that that's how you want us to do it. You want us to do some questions before we do a deep dive. So today, questions first, deep dive. Questions, deep dive. Questions, deep dive. So, doctors, please go there. We only have 3 likes, and that is not good. Go there and click on the like and subscribe button, and let's move on. That's how we do it, so that many people can get it. So please go to our YouTube and click on the subscribe button and the like button right now. All right. And then if you're also watching us on Facebook, do the same. And then let's move. So the first question is this. You have a 52-year-old woman who presents to the clinic with a history of 13 months of amenorrhea, 52 years. She reports no hot flashes and her physical exam is unremarkable. She has no history of significant medical issues or surgeries. What is the most appropriate next step in confirming her diagnosis? All right. 52-year-old woman presents to the clinic with a history of 13 months history of amenorrhea. She reports no hot flashes and her physical exam is unremarkable. She has no history of significant medical issues or surgeries. What is the most appropriate next step in confirming her diagnosis? A, serum follicle stimulating hormone level. B, serum estradiol level. C, diagnosis based on history alone. D, endometrial biopsy. E, pelvic ultrasound. What's the correct answer? Is it A? Is it B? Is it C? Or is it D? Doctors, I'm checking on. Okay, I can see it now. Because I was initially checking on YouTube to make sure that you guys are there. And now I can see that we have some people join us on YouTube as well. So please click on the like button on YouTube as well, so that this can go as far. So 52-year-old woman, what's the most appropriate next step in confirming her diagnosis? Is it A, follicle stimulating hormone? B, is it serum estradiol level? C, is it diagnosis based on history alone? D, endometrial biopsy? Or E, pelvic ultrasound? And the correct answer is C. C. Diagnosis based on history alone. Why? Because menopause is a clinical diagnosis, So I saw that somebody had written A. Someone had written A, and that was wrong, right? And I like that Dr. Khadija said something here. Age is more than 45 years. Therefore, no test is required. Beautiful. No test is required. So menopause is a clinical diagnosis made after 12 months of amenorrhea without any pathologic or physiologic causes, right? So routine laboratory testing, including FSH or estradiols, is not required. Let me say it again. Routine laboratory testing, including FSH or estradiol levels, is not required for diagnosis in a woman with typical symptoms and no risk factors. So the correct answer is C. So why is A wrong? Because I saw that somebody shared A. A is wrong because Even though in menopause you will see elevated FSH, okay? Typically in menopause, you will see elevated FSH due to the loss of ovarian follicular activity. But it is not necessary. Let me say that again. It is not necessary for diagnosing menopause in a woman of typical age. Testing is more useful in younger women to evaluate for early menopause or primary ovarian insufficiency. Hello, doctors, please. Are you all with me? Are you all with me? So please, when you start practicing or when you're preparing for your MCQE1, please, if you have any patient who comes in, patient is 55, doctor, please, I need you to request my hormone levels because I'm menopausal. Smile and tell the patient that menopause is a clinical diagnosis. Okay, what about serum estradiol level? It goes to the same thing, you know. Serum estradiol level, it goes back to the same thing. Estradiol levels are low in menopause, but they fluctuate during the menopausal transition. And measuring estradiol is not reliable. You don't need to do it. What about endometrial biopsy? This is another learning point you need to know. Please write it down, because endometrial biopsy is indicated for patients with postmenopausal bleeding, right? So the patient has stopped having menses for a long time, and then for whatever reason, the patient starts bleeding again. That's when you do endometrial biopsy. Or if there are risk factors for endometrial cancer and this patient does not have any abnormal symptoms to warrant biopsy. Hello, doctors, please. Are we all on the same track? Are we all on the same track? Are we all tracking together? And then pelvic ultrasound, used to assess structural abnormalities or endometrial thickness in cases of irregular bleeding. It is unnecessary for diagnosing menopause. So let's go to the next point. Doctors, we have 115 people on the stream. Please, we want to hit 200 today. So please, in your WhatsApp groups, in your Telegram groups, in your Discord groups, in your Facebook groups, share the link, you know, so that people can also come and enjoy on this feast, because we are all studying together. We want to get as many doctors, whether CMGs or IMGs, into residency, practice-ready assessment as possible, right? That is our goal, and that's our aim. Let's go to the next question. A 47-year-old woman, and this one, I really like it, because when you are learning menopause, one thing you need to pay attention to is age, right? So a 47-year-old woman presents with irregular menstrual cycles, mood swings, and occasional hot flashes over the past year. Now, her physical examination and pelvic ultrasound are unremarkable. Which of the following best describes her current phase of reproductive aging? A, early menopause. B, primary ovarian insufficiency. C, postmenopause. D, perimenopause. And E, premature ovarian failure. You know, if you've not mastered menopause in relation to age and all those things, it will be difficult to get this. So what's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? And today we'll be doing some deep stuff so far as age is concerned and menopause is concerned. Is it A? Is it B? Is it C? Is it D? Or is it E? It looks like everybody is going for D, and the correct answer is perimenopause. So perimenopause refers to the transitional period before menopause, right? And it is characterized by irregular menstrual cycles and symptoms such as hot flashes and mood swings. And this phase can occur several years before the final menstrual period, all right? So that's perimenopause for you. That's perimenopause for you. Doctors, please keep hitting on the subscribe button on YouTube. Let's go. So now, please, I'll take my time here, especially on this slide, so that we can get the best out of it. Now, early menopause. Doctors, these words are very important in your MCQs. These words are very, very important. What is the definition of early menopause? Early menopause is defined as menopause which occurs between 40 and 45 years old. Please, I need you to write this one down in your notebook. And when you are done, those who have my WhatsApp line, I want you to send me the notes you took. I want you to take screenshots of the notes you took. Revolution. We want to, you know, We want to connect with you. When you are done, send me a screenshot of the notes you took, during today's class on my phone number. I'll share my phone number. In fact, let me share it right away because I want to connect with you. Yeah, my phone number is tracking at the base of the video. So please, early menopause definition. It is defined as menopause, but at what time? Between 40 and 45 years old. But remember that the patient we had, that patient is still having some bleeding. So this is not early menopause. But please, write this down. Early menopause. Number 2, what is primary ovarian insufficiency in relation to age? It refers to ovarian failure before age 40. Before age 40. And in those patients, so primary ovarian failure, if I were you, I write primary ovarian failure on my sheet and then write before age 40. And they present with amenorrhea, elevated follicle stimulating hormone level, and they have hypoestrogenism. So they have elevated FSH, decreased estrogen, amenorrhea, and it occurs in patients before the age of 40. So primary ovarian insufficiency before age of 40. Early menopause 40 to 45. Let me move on. Doctors, please, are you picking up the issue with the ages? Please, are you picking it up? I want to really know because it is very important. Because the age alone can help you to differentiate between a lot. Now, what about postmenopause? Postmenopause, the period after menopause, all right? And it is diagnosed after 12 consecutive months of amenorrhea. And this patient is still experiencing menstrual irregularity. Therefore, you can't say this patient is postmenopausal. And then premature ovarian failure, an older term which is synonymous with primary ovarian insufficiency. So if you see the B, the answer B, okay? The answer B there, the primary ovarian insufficiency we talked about. Another name is premature ovarian failure, and it is defined as ovarian failure before 40 years. And this patient does not meet that criteria. All right? Doctors, please, can I move on? Because in this slide alone, we spilled out so many things. I've spilled out so many things. In this slide alone, so much has been spilled out. By the way, is there anybody who wants to join me live? Is there anyone who wants to join me live on this stream? If yes, let me know and I'll share my link and then you can join me. Is there anyone who wants to join me live? I'll share my screen or my link and then you can join me. If you want to join me live, let me know. Okay? All right. So if you want to join me live, just type, yes, Dr. Boone, I want to join you live. All right. Next question. You have a 42-year-old woman who is diagnosed with early menopause after presenting with amenorrhea for 14 months and an elevated FSH level. Which of the following long-term risks is most strongly associated with early menopause? Okay, I think 2 people want to join me so that they can help me to read the questions. So I'm going to share the link right now, and then you can join me. It's in the comment section right now. So if you want to join me, you can click on the link and then you can join me, okay? So a 42-year-old woman is diagnosed with early menopause after presenting with amenorrhea for 14 months. Remember, 42 years old and an elevated FSH level. Which of the following long-term risks is most strongly associated with early menopause? Before you even write the answer, ask yourself, what is happening in early menopause? Remember that early menopause, estrogen levels will go down, FSH levels will go up. So the other question, the other way you can look at this question is that this question is asking you, hey, what are the things or what are the complications which can occur when estrogen levels decrease? What are the things which can occur when estrogen levels decrease? And then what the best way you can notice this, if you know what happens if a patient has prolonged estrogen exposure. So if you have a patient with early menarche, late menopause, maybe let's start from there. Talk to me. I want to have this conversation with you. with these risk factors or these complications, breast cancer, cardiovascular disease, endometrial cancer, pulmonary embolism, and thyroid disease, which of these occur because the patient had early menarche, that is early menstruation, and late menopause? Can you help me? Which of these occurs if the patient has early menstruation and late menopause? I want to know. Breast cancer, cardiovascular disease, endometrial cancer, pulmonary embolism, and thyroid disease. Which of them can occur because the patient had early menarche and late menopause? Then after that, we will flip it. So Dr. Irene says endometrial cancer. Beautiful. So endometrial cancer will occur if the patient is exposed to long-term estrogen. So that means endometrial cancer is a risk factor in, like, if there is late menopause. That is it. So endometrial cancer is a risk factor if there's late menopause and early menarche. What again? Good. Dr. MJ also says breast cancer. So that means that these two doctors are telling us indirectly that if you have a patient who had early menstrual cycles, say 9 years, 10 years, 8 years, 11 years, and then late menopause, say 55 years, because they were exposed to estrogen for a long period, they have a risk factor for endometrial cancer and they have a risk factor for breast cancer. But let's go back to this question. I have another question. Which of these conditions, breast cancer, cardiovascular disease, endometrial cancer, pulmonary embolism, and thyroid disease, does estrogen protect women against? Because it's a common thing in medicine that, there are some conditions women have a less risk until they become menopausal. So please, which of these does elevated estrogen level protect women from? I want to know. Beautiful. So Dr. Dogua says B. So it looks like the class is saying that if a patient has estrogen levels are high, right, or like normal estrogen levels in reproductive ages, it protects them against cardiovascular disease. So now, let's go back to this question. You have a 42-year-old woman who is diagnosed with early menopause. That means that estrogen levels will drop, right? After presenting with amenorrhea for 14 months and elevated FSH level, which of the following long-term risks is most strongly associated with early menopause? So please now give me the answer. Is it A, is it B, is it C, or is it D, or is it E? So in early menopause, what is happening? That means that estrogen levels have dropped, right? Estrogen levels have dropped. And if its estrogen levels have dropped, then the correct answer is B, 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 B. Thank you very much. I'm very happy about the way we reasoned through it. So early menopause is associated with increased risk of cardiovascular disease due to the loss of estrogen's protective effects on lipid profiles, vascular function, and inflammation. So remember that up until menopause, assuming you have twins, one is a male, one is a female, up until menopause, the female is more protected against cardiovascular disease as compared to the male. Why? Because of estrogen levels. Now, when she becomes menopausal, then her risk of cardiovascular disease is similar to that of the male twin. So why are the other options incorrect? Estrogen exposure over lifetime increases the risk of breast cancer, but early menopause reduces the duration of estrogen exposure. Therefore, it reduces breast cancer risk. Doctors, please, are we all on the same page? I want to make sure. Are we all on the same page? Please, are we all on the same page? Before I move on to the next point, are we all on the same page? Are we all together? That if a woman becomes menopausal early, it does not pose a risk to breast cancer. Number two, endometrial cancer. Endometrial cancer is also related to prolonged estrogen exposure. Therefore, early menopause decreases the risk due to reduced estrogen stimulation of the endometrium. Beautiful. Beautiful. So it looks like people are really, really following. Okay. Number 3, pulmonary embolism. Why is pulmonary embolism wrong? Hormonal changes in menopause are not a primary cause of thromboembolic events. Rather, these risks are more associated with exogenous hormone use, so like oral contraceptives or hormone replacement therapy in menopausal women. That is when they have an increased risk of pulmonary embolism. And thyroid disease. Thyroid disorders are not directly associated with menopause, though they can affect menstrual cycles and mimic menopausal symptoms. Doctors, please, if you are flowing with me so far, type yes, 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 yes. I really like the participation in the class. Type yes, yes, yes. I want to make sure. Type yes, 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 yes. Type yes, 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 yes. Okay, good. Next question. You have a 38-year-old woman. Haha. Remember that I told you that take care of the ages, right? So you have a 38-year-old woman who presents with amenorrhea for 10 months and occasional hot flashes. Her laboratory results show elevated FSH and low estradiol levels. Her thyroid stimulating hormone and prolactin levels are normal. What's the most likely diagnosis? A, perimenopause. B, early menopause. C, primary ovarian insufficiency. D, polycystic ovarian syndrome. And E, hypothalamic amenorrhea. What's the correct answer? Is it A, is it B, is it C, or is it D, or is it E? Doctors, click on the like and subscribe button. Invite your friends. Please send it to the friends. If they are in a WhatsApp study group, tell them, hey, stop and come and join Dr. Bruni. After that, you can go back. After that, you can go back. After that, you can go back. After that, you can go back to your studies. Now, let's all study together. All right? So what is the answer here? Remember that I told you to pay attention to age. When we're doing the definitions, we talked about menopause, we talked about early menopause, we talked about primary ovarian insufficiency and all those things. So what's the correct answer? The correct answer is C. So the answer is primary ovarian insufficiency, and primary ovarian insufficiency is defined as the cessation of ovarian function before age 40. And then early menopause, please. So primary ovarian insufficiency is before age 40. What about early menopause? Who remembers? Can you please type it for me? Early menopause. Early menopause. Early menopause. What is the age? What is the age that you define that this patient has developed early menopause? Early menopause. Beautiful. 40 to 45 years. Thank you. Doctors, please don't forget that when we are done, take a screenshot of your notes, so that I can connect with you on the paper you took your notes on and send it to me on my phone number at +1 306 891 5649. Okay, good. So let's continue here. Why are the other options wrong? Perimenopause occurs after the reproductive years, but before menopause. Okay, it typically involves irregular cycles. Perimenopause typically involves irregular cycles. That is perimenopause for you. Irregular cycles and fluctuating hormonal levels, not the persistently elevated FSH level. And then early menopause is menopause before age 45. But this condition occurs in women younger than 40, making POI the correct diagnosis. So that is primary ovarian insufficiency, right? Polycystic ovarian syndrome is characterized by chronic anovulation, hyperandrogenism, and polycystic ovaries. Okay, and hormonal levels are typically normal or altered differently from POI. That is primary ovarian insufficiency. And what about hypothalamic amenorrhea? It is caused by stress and excessive exercise or weight loss, and typically shows low FSH. Meanwhile, in menopause, we know that FSH levels are high, right? And low estradiol. Okay, next question. Which of the following hormonal changes is most characteristic of natural menopause? Today, we want to delve deep into menopause. Delve deep into it. So, which of the following hormonal changes is most characteristic of natural menopause? Natural menopause. Which of these is most characteristic of natural menopause? A, decreased FSH and estradiol levels. B, increased FSH and decreased estradiol levels. C, increased FSH and increased estradiol levels. D, decreased FSH and increased estradiol levels. And E, decreased FSH and unchanged estradiol levels. If you don't master your concepts, then Dr. Boni will be able to trip you easily in these questions. So some are going for A, some are going for B, some are going for A, that is decreased FSH and estradiol levels, and some are going for B, which is increased FSH and decreased estradiol levels. Doctors, where do you stand? I want to know. Where do you stand? Is it decreased FSH levels and increased and decreased estradiol levels? Where do you stand, doctors? I want to know. I want to know, doctors. So the correct answer is B. So let me go back to the. So please, if you wrote C or A, it's wrong, right? So it's increased FSH and decreased estradiol levels. Like in menopause, ovarian follicular depletion leads to loss of negative feedback on the hypothalamic pituitary axis, right? And it increases or causes an increase in FSH and a decrease in estradiol levels. So that is it. In menopause, ovarian follicular depletion leads to a loss of negative feedback on hypothalamus pituitary axis, causing an increase in FSH and decrease in estradiol levels. So, why are the wrong answers wrong? Decreased FSH and estradiol levels, FSH increases rather in menopause due to the negative feedback. Okay. What about C? Increased FSH and increased estradiol levels. Estradiol levels decrease significantly in menopause, so that's also wrong. And what about D? Why is D wrong? Decreased FSH and increased estradiol levels. This pattern is typically of the reproductive ages. So anyone who is, still in the reproductive age, this pattern is typical of reproductive years or conditions which increase estrogen production, not menopause. And what about decreased FSH and unchanged estradiol levels? This does not occur in menopause. All right. So the correct answer is B. Increased FSH, decreased estradiol levels. So now, let's do a deep dive into the introduction to menopause. But before that, I want to talk to you about MedDrills. So we just did our first set of MedDrills for January, and we ended. The candidates decided on what they wanted. So MedDrills is, so just imagine Dr. Bruni is the doctor here, and the other doctors have been lined up, and we talk about it, right? So it's like a fast-paced thing, and we did it for ethics. It's a top-up class, and it is for everybody, whether you're a MedCognito candidate or not. It's for everybody. And both MedCognito candidates and non-candidates can join, okay? The interesting thing about MedBullets is that, or MedDrills is that you tell us what you want us to cover, and then we fit a time, and then I spend some time with you. Because you go like, oh, Dr. Bonnet, I think I have some weakness in ethics or something, right? Then we do that. So we did that for January, and currently the January one is done. And, the candidates were really happy about it. Someone said, I enjoyed the class, and thank you for your, to our tutor for another wonderful class. Concepts were well broken down. Thank you, MedCognito. Another doctor said, thank you for today's class. It was very enlightening. Now, in February, the candidates said that, Dr. Bruni, we want you to deal with psychiatry for us, mental health issues, psychiatry. Therefore, we've selected 2 dates. Initially, I announced February 4th, but we've changed it to February 10th and February 18th. 2 days for psychiatry. And don't forget that tonight you're going to do psychiatry as well. Okay? So we want to make sure that we've covered the whole ground in psychiatry before your exam come April, May, and then come August and come October. So please mark your calendars. February 10th, 2025. February 18th, 2025. You have to come and get drilled, bombarded, and thoroughly prepared for psychiatry for the MCCQE1. All right? So please write it on your calendar and put it in your phone so that when it is time, you can join us. Now, if you want to register, if you're in MedCognito already, it is free. It is free. But if you're not a MedCognito candidate, we have some people joining us and they've decided to come for the other classes as well. Some people also came for the first one and they were like, man, why don't I just purchase the entire MedCognito program so that I have everything? So some people also did that. So doctors, it's all up to you. So you can just scan the QR code and you are good. And you can join us and then we will move on from there. So please mark your calendar. Even if you purchase MedCognito for just 1 month and it is within that time, February 8th and February 18th, you will get MedDrills for free. You get MedDrills for free. All right? Okay. So now let's go to the deep dive into the introduction of menopause. Now, let's define menopause. So, natural menopause is permanent cessation of menstrual periods. All right? And it is confirmed retrospectively after 12 months of amenorrhea without other pathologic or physiologic causes. So, usually, menopause is defined or is seen or is confirmed retrospectively, right? The median age of women becoming menopausal is 51.4 years. All right, 51.4 years. That's the median age. And the underlying reason why patients develop menopause, even though it's a physiologic thing, we just want to understand it because we are doctors, right? So there is ovarian follicular depletion, and this leads to hypoestrogenemia, right? So levels of estrogen in the blood levels decrease because of ovarian follicular depletion. And this leads to high follicle stimulating hormone levels. That's why we are saying that in menopause, FSH levels are elevated, right? Estradiol levels are decreased. Okay, now, what are the phases of menopause? What are the phases of menopause? So we have perimenopause, which occurs after reproductive years, but before menopause. So the transition period between the reproductive years and menopause itself. And what are the characteristics? Number one, there's irregular menstrual cycles. Number two, there are endocrine changes. So you see fluctuating estrogen and FSH levels. All right. And number three, you see symptoms like hot flashes, night sweats, mood changes, and sleep disturbances in the patient. Right? You see these changes there. Now, remember, we also talked about early menopause when we're talking about the questions, when we're dealing with the questions. And I said that, note this, early menopause occurs in women between the ages of 40 to 45 years. And they are associated with risk factors like cardiovascular disease. If you remember, the objective, the MCC objective was talking about this. So cardiovascular disease, bone loss, right? Cognitive decline. These are the associated risks of early menopause. So please note it down. 40 to 45 years, associated risks include cardiovascular disease, bone loss, cognitive decline. Please, can I proceed? Doctors, can I proceed? If you don't give me the permission, I will not proceed. So give me the permission before I can proceed, please. Kindly give me the permission, then I can proceed. Please, give me the permission and I can proceed. Okay, good. All right. So early menopause, 40 to 45 years, cardiovascular disease, bone loss, cognitive decline are associated risks with it. Now, what about primary ovarian insufficiency? Remember that I told you it's all about ages, right? So primary ovarian insufficiency, look for that patient who is less than 40 years, and it's also associated with increased cardiovascular risk, accelerated bone loss, and cognitive function issues. Now, what are the clinical features of menopause? Clinical features of menopause. They are vasomotor symptoms, okay? So like hot flashes, night sweats, okay? sleep disturbances, fatigue, mood changes like anxiety, depression, vaginal dryness, and dyspareunia, so pain during intercourse, and cognitive decline or memory issues. Now, there are also endocrine changes, high FSH concentrations, and I'll be drumming this till we all get it very well. Please, doctors, don't forget, take notes, and after that, take a picture and send it to me on +1 306 891 5649. Okay. Now, so while FSH levels are elevated in menopause, estrogen levels are low. So you have high FSH concentration levels and then hypoestrogenemia. All right. Now, what's the diagnosis of, like, how do we diagnose menopause? We use the clinical criteria. That was one of the questions we asked earlier. So 12 months of amenorrhea without other causes. So you look retrospectively, and then you realize that these patients had amenorrhea and there were no other causes. There's elevated FSH levels. So elevated FSH levels is only supportive. It is not diagnostic of menopause, right? And early menopause and primary ovarian insufficiency, those patients who develop cessation of menses between 40 to 45 years or before 40 years, you need to do some additional evaluation. You want to check their hormonal profile, their FSH, their estradiol, and you want to consider secondary causes like autoimmune conditions, genetic disorders, right? You want to do these things. Now, what are the health implications of menopause or early menopause and primary ovarian insufficiency? So, on cardiovascular health, for your MCCQE1 exam, there's increased risk of myocardial infarction and stroke, all right, because of the loss of the protective effect of estrogen. Number 2, on bone health, there is associated bone loss leading to osteoporosis. Number 3, on cognitive health, there's increased risk of dementia or cognitive impairment, right? And if you have patients who even have elective bilateral oophorectomy, they also present with similar symptoms. They have increased risk of menopause-related complications like the cardiovascular health issues, the bone health issues, the cognitive health issues, and impact depends on the age and hormonal replacement therapy that the patient will receive. So doctors, please, the health implications of early menopause and primary ovarian insufficiency. Can I proceed from there? Can I proceed from there? Can I move on from there, doctors? Please, can I move on? Okay, good. So if you want to remember this very well, remember 4 C's. Four C's, right? 4 C's. The 4 C's are 4 C's of early menopause and primary ovarian insufficiency. Number 1, there's cardiovascular risk. Number 2, there's cognitive decline. Number 3, there is connective tissue issues, that is bone loss, that's leading to osteoporosis. And number 4, there's complete menstrual cessation. All right. So the 4 C's of primary ovarian insufficiency and early menopause are cardiovascular risk, increased risk of myocardial infarction, increased risk of stroke, cognitive decline, connective tissue issues, and then complete menstrual cessation. Now, if you want to remember, have a mnemonic for symptoms of estrogen decreasing in patients with menopause, then remember the word hot flash. Remember that we said that patients with menopause, they develop hot flashes. So remember that word hot flash, and this will help you. So the H stands for they will develop hot flashes. The O stands for the fact that they have increased osteoporosis risk. All right. So please write hot flash in your book. Write hot flash in your book. And then remember the first one. The first one stands for hot flashes. They will develop hot flashes. So H, they have hot flashes. O means they have osteoporosis risk. Osteoporosis risk. Osteoporosis risk. So the first is hot flashes. The next is osteoporosis risk. Then the T stands for temperature regulation changes. Temperature regulation changes. I'm just trying to make remembering osteoporosis ridiculously simple. Okay, no, remembering menopause symptoms with this acronym ridiculously simple. So H is hot flashes, O is osteoporosis risk, T is temperature regulation changes. Then F is fatigue, right? Then L is loss of estrogen, loss of estrogen. Then A is anxiety and mood changes. A is anxiety and mood changes. And S stands for sleep disturbances. Sleep disturbances. And H stands for hair thinning and vaginal dryness. Hair thinning and vaginal dryness. So please, doctors, if you want to remember, features of menopause in a patient with decreased estrogen levels, remember the word hot flash. And remember, hot flashes, osteoporosis risk, temperature regulation issues, fatigue, loss of estrogen, anxiety and mood changes, sleep disturbances, and hair thinning and vaginal dryness. Doctors, please, does this make sense? Does this make sense? Does it make sense? If it does, just type yes, Dr. Bruni. It makes sense. It makes sense. I really love what you're doing. I really love what you're doing. Share the link with your friends, so that they can join us and get the best out of what MedCognito has to offer. All right, let's move on. Let's move on from there. So exam tip, the exam tip I want us to go with is red flag. If menopause is occurring in patients less than 40 years, it's always abnormal and requires further evaluation for primary ovarian insufficiency. Primary ovarian insufficiency. And when you're also focusing on, dealing with patients with primary ovarian insufficiency and early menopause, focus on the health risks and bone health, like what the MCC objective talked about. So now, I'm going to take you into something very, very unique that candidates trip over in board exams. Candidates really struggle with this in board exams. And I'm going to take you through something very, very important and significant. So we're going to evaluate or do some questions on menopause in a woman who is, I think it should be less than 40 years. Please, this is wrong. It should be less than 40 years, not more than 40 years. Less than 40 years. Okay, let me just correct it. It should be less than 40 years. Less than 40 years. If I can correct it right away, that would be very good. Less than 40 years, not more than 40 years. Less than 40 years. Less than 40 years. Let me see. Okay. Okay, good. It's corrected automatically. That's beautiful. I like that. So less than 40 years. Okay, now let's go. So let's take this first question. You have a 39-year-old woman who presents with irregular menses, fatigue, and occasional hot flashes over the past 4 months. She denies any significant weight loss, galactorrhea, or use of medications such as dopamine antagonists. Laboratory results show the following. FSH is normal, TSH is normal, prolactin is 60. The normal range is less than 20 according to, the standard I used here. Estradiol is normal. A brain MRI is ordered and shows no pituitary adenoma. What's the most likely cause of her symptoms? A, subclinical hypothyroidism. B, functional hyperprolactinemia. C, primary ovarian insufficiency. D, non-classical congenital adrenal hyperplasia. And E, perimenopause. 39-year-old woman presents with irregular menses, fatigue, and occasional hot flashes over the past 4 months. She denies any significant weight loss, galactorrhea, or use of medications such as dopamine antagonists. Laboratory results show the following: FSH normal, TSH normal, prolactin 60 nanogram per mil, and the normal prolactin level is less than 20 nanogram per mil. Estradiol is normal. A brain MRI is ordered and shows no pituitary adenoma. What's the most likely cause of her symptoms? A, subclinical hypothyroidism. B, functional hyperprolactinemia. C, primary ovarian insufficiency. D, non-classical congenital adrenal hyperplasia. And E, perimenopause. I'm very happy. Dr. Maria, you want to check it again. You went for E, right? I see a lot of doctors, Dr. Benedicta, Ishon Glover, and every other doctor is going for B. And Dr. K. Thomas went for C. Dr. Maria Florence for Ortiz went for B. Okay, so what's the correct answer? The correct answer is B. This is functional hyperprolactinemia. Okay, functional hyperprolactinemia. So functional hyperprolactinemia refers to elevated prolactin levels caused by a non-tumor related factor. So that is why when the patient did the MRI, they didn't see any tumor, right? So what are the causes of functional hyperprolactinemia? Like stress, like idiopathic prolactin secretion, or minor hypothalamic pituitary axis dysregulation. All right. And the absence of a pituitary adenoma on MRI and the normal estradiol level supports this diagnosis of functional hyperprolactinemia. Now I continue. Hyperprolactinemia disrupts gonadotrophin releasing hormone, that is GnRH, pulsatility. All right, leading to irregular menses and symptoms which mimic perimenopause. Now, why are the other options wrong? Subclinical hypothyroidism. This condition is often associated with mild TSH elevation. All right. But this patient, the TSH was normal. And this patient has normal TSH, so it rules out thyroid dysfunction. What about primary ovarian insufficiency? Remember that we said primary ovarian insufficiency occurs in patients less than 40 years and their FSH is elevated. But this patient, even though the patient was 39 years, the FSH was normal. All right. So this patient has normal ovarian function based on her hormonal levels. What about non-classical congenital adrenal hyperplasia? Typically, this particular condition presents with signs of hyperandrogenism, right? So like hirsutism, acne, which the question didn't talk about. So in this case, this patient doesn't have non-classical congenital adrenal hyperplasia. And what about perimenopause? You know, even though irregular cycles and hot flashes are consistent with perimenopause, her age, which is less than 40 years, and elevated prolactin make hyperprolactinemia the better explanation. So that is why we went for that. All right. Doctors, thank you very much for your participation in the class today. Please keep liking and subscribing to the YouTube channel, and let's keep growing it. Okay, next question. You have a 48-year-old woman who presents with irregular menses and hot flashes for the past 14 months. She denies any other significant medical history. Her last menstrual period was 13 months ago. Physical exam is unremarkable, and pregnancy has been ruled out. What's the most likely diagnosis? This is very simple. This is very simple. Just answer it and let's move on. This is very, very simple. Just answer it and let's move on, doc. This is very, very simple. Answer it and let's go. Very, 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 very simple. Answer it and let's go. This is clinical menopause. We've already learned it, read it, consumed it, digested it. We know what early menopause is. We know the features of hyperprolactinemia. We know transition to menopause. This is easy. Let's move on. You have a 42-year-old woman. Remember the number is 42, right? Who presents with irregular periods and hot flashes for the past 8 months. Pregnancy has been ruled out. Laboratory results show elevated FSH and normal TSH and prolactin levels. What's the next best step in her management? 42-year-old woman presents with irregular periods and hot flashes for the past 8 months. Pregnancy has been ruled out, and laboratory results show elevated FSH and normal TSH and prolactin levels. What's the next best step in her management? A, confirm early menopause based on clinical presentation. B, repeat FSH levels in 6 months. C, evaluate for hyperprolactinemia. D, Evaluate for other endocrine disorders. E, start hormone replacement therapy immediately. I like this question because the answers I'm getting vary. Some are saying C, some are saying B, some are saying A. I really like it because it has torn the class apart. I like it. I really like it. So what's the correct answer? Next best step. The next best step is A. You want to confirm early menopause based on clinical presentation. Remember we talked about early menopause. Early menopause is defined as menopause occurring between 40 and 45 years, and it is characterized by irregular menses, elevated FSH, and symptoms like hot flashes, right? And no additional evaluation is required in this case, as her thyroid and prolactin levels are normal. And you will realize something. I'll be doing a deep dive into these cases, and you will come to appreciate that in cases of early menopause, that's number one, and number two, primary ovarian insufficiency, you want to do some investigations, and we'll take our time and go through that. Okay, so now, why are the other options incorrect? Repeating FSH levels in 6 months is not required if the current FSH levels confirms menopause and symptoms align with diagnosis. There's no need. Okay, there's no need. And evaluate for hyperprolactinemia. Remember that her prolactin levels are normal, and so it rules out hyperprolactinemia. And D, evaluate for other endocrine disorders. Her clinical features and lab results already support early menopause without evidence of other endocrine dysfunction. And that is why you're not going to go for D. What about E? Start hormone replacement therapy immediately. Hormone replacement therapy is a treatment option, but not the next step for confirming the diagnosis. So that is why A is correct. Let's go to the next question. You have a 41-year-old woman who presents with irregular menses and hot flashes. Now, her pregnancy test is negative. Lab results show normal TSH and prolactin levels. What is the role of measuring FSH in this patient? A, to confirm diagnosis of clinical menopause. B, to rule out thyroid disease. C, to support diagnosis of early menopause. D, to evaluate for perimenopause. And E, to screen for ovarian failure. So 41-year-old presents with irregular menses and hot flashes. Her pregnancy test is negative. Lab results show normal TSH and prolactin levels. What's the role of measuring FSH? Is it to confirm the diagnosis of clinical menopause? Is it to rule out thyroid disease? Is it to support the diagnosis of early menopause? Is it to evaluate for perimenopause or to screen for ovarian failure? It looks like the answer is C. So we learned between 40 and 45 years, we are dealing with early menopause. Now, I think some questions have come in. Let me just go back to the comments and just read them. So, Dr. Irene Owuswajiman said, Dr. Bruni, please, for early menopause, the 12-month time interval doesn't count. It does, Doc. It does count. It does count. Because you can only say the patient is menopausal after the 12 months. All right. And then for diagnosing early menopause, do we need a amenorrhea duration of 12 months or not? You do. That is another question from Dr. Khadija Iram. But then this question was saying that, are you going to wait like somebody who is 42 years? I understand where you're coming from in relation to the fact that we have the 1 year retrospective view, right? But yeah, 1 year retrospective view. Let me see. It says the other question that the thing was talking about 8 months. So 42-year-old woman presents with irregular pregnancy has been ruled out. Lab results show elevated FSH and normal thyroid stimulating hormone and prolactin level. What's the next best step in the management? Yes. So let me just go back here. This should be not 8 months. It should be something like maybe 14 months or so. Okay. it should not be 8 months. That is when what we are dealing with becomes correct. So thank you very much for pointing that out. Thank you very much for pointing that out. It should be 14 months or, something above 12 months. That is when A becomes the correct answer. So thank you very much for pointing that out. Good. That means that people are paying attention in the class. Okay. I think we already said the answer for this is C, right? You support a diagnosis of early menopause. Okay, let's go to the next question. You have a 45-year-old woman who presents with irregular periods for 8 months. She denies hot flashes, mood changes, or sleep disturbances. Her laboratory results show FSH of 25, FSH level is 25, which is elevated. Estradiol is 150, which is normal. TSH is 1.5, which is normal. Prolactin is 12, which is normal. What's the next best step in evaluating the patient? A, repeat FSH and estradiol levels in 6 months. B, measure anti-Mullerian hormone levels. C, diagnose perimenopause and provide symptomatic treatment. D, evaluate for ovarian granulosa cell tumor. E, perform a bone density scan. Is it A, is it B, is it C, or is it D? Is it A, is it B, is it C, or is it D? So for Dr. Koro, for us to say this is early menopause is the time, like the age, 40 to 45. And so they also have to get the 12-month cycle with no bleeding before you can finally say that this is early menopause. All right. But if the menstrual cycle is irregular around that time, you can only say probably the woman is in perimenopause. So far as there's some irregular bleeding, it is perimenopause. So what's the correct answer for this one? The correct answer is D. You want to evaluate for ovarian granulosa cell tumor. And why am I saying that? Let's go back to the question. The question says that the FSH is 25, which is elevated, but then the estradiol is normal. Remember this very well. FSH is 25, but estradiol is what? Normal. Now I have a question. In menopause, what happens to FSH and what happens to estradiol? In menopause, what happens to FSH and what happens to estradiol? I want to know. So for those who are confused, in menopause, what happens to FSH? Good. Dr. Nandini says FSH increases. What about estradiol? What about estradiol? Does estradiol increase or decrease? Because we did a whole question here on this whole thing. In menopause, does FSH increase or decrease? Does estradiol increase or decrease? Please type the answer and then we can go on to the question. So, in menopause, FSH increases, estradiol decreases. But this patient, FSH is elevated and estradiol is normal. So the combination of elevated and normal to high estradiol in a perimenopausal age woman is suspicious for ovarian granulosa cell tumor. So please, yes, we are doing menopause, but it looks like you need to really pay attention, right? And that's why I threw this particular question in there. In menopause, FSH increases, estradiol decreases. But this patient, FSH has increased, estradiol is normal, right? And most of the time, in ovarian granulosa cell tumor, estradiol is either normal or elevated. Okay, so these tumors can cause menstrual irregularity while maintaining high estradiol levels despite elevated FSH. So why are the other answers wrong? Like A, repeat FSH and estradiol in 6 months. Delays in diagnosing a potential ovarian tumor can be problematic. Number 2, what about measuring anti-Mullerian hormone levels? Anti-Mullerian hormone is useful for assessing ovarian reserve, but is not relevant in suspected estrogen secreting tumors. Okay, so doctors, please remember, Menopause. FSH is elevated, estradiol is decreased. Ovarian granulosa cell tumor. FSH is elevated, estradiol is either normal or increased. Okay. Good. And then C, diagnose perimenopause and provide symptomatic treatment. It does not account for the elevated estradiol level, which is atypical for perimenopause. Okay. Did I say the estradiol level is normal? Yeah. So it's either normal or elevated. And then perform a bone mineral density scan. So while important in menopause, this step is unrelated to the primary presentation. And so you don't need to really worry your head about that. Next question. You have a 46-year-old woman who reports irregular menses for 6 months, or for 7 months, along with new onset constipation, cold intolerance, and diffuse hair thinning. Her lab results show FSH is normal, TSH is elevated, prolactin is 18, which is normal. Which of the following best explains her irregular menses? A, menopausal transition with concurrent hypothyroidism. B, subclinical hypothyroidism. C, overt hypothyroidism causing menstrual irregularity. D, early menopause. E, functional hyperprolactinemia. Please look at the values very well. A, FSH is normal. TSH is elevated and prolactin is 18 nanogram per ml. And this patient is 46 years old. She reports early menses for 7 months, along with new onset constipation, cold intolerance, and diffuse hair thinning. And FSH is normal. So the answers here are menopausal transition with concurrent hypothyroidism, subclinical hypothyroidism. C, overt hypothyroidism causing menstrual irregularity. D, early menopause. Early menopause is wrong because we know that early menopause occurs between 40 and 45 years. So that is wrong. Functional hyperprolactinemia, usually, at least we'll see an elevated prolactin level. So D and E are wrong. Now, A, menopausal transition with concurrent hypothyroidism. In menopausal transition, I'm expecting FSH levels to be elevated. Meanwhile, in this patient, FSH is also normal. Subclinical hypothyroidism, they may have elevated TSH, but they may not have symptoms like cold intolerance, diffuse hair thinning. Doctors, please, are you following me? Therefore, if we reason through this case very well, A is wrong, B is wrong, D is wrong, and E is wrong. And the correct answer is C. This is overt hypothyroidism, which is causing menstrual irregularity. Right? This is overt hypothyroidism. Why? Because the patient has elevated TSH and symptoms. Meanwhile, A, menopausal transition, unlikely because the FSH is normal. What about subclinical hypothyroidism? It's defined by mild TSH elevation without symptoms. What about early menopause? It requires elevated FSH, but in this case, the FSH is normal. What about functional hyperprolactinemia? It would present with elevated prolactin levels, but in this patient, prolactin levels are normal. Dr. Sabine says, oh, I see. Doctors, please, I have this question. Is this class opening your eyes to things you've not paid attention to? Please, I want to know. Is it opening your eyes? Is it opening your eyes? I want to know. I really, really want to know. Because, for many of us, we just do quick reading. I told you that because this exam is now going to focus on MCQs alone, you want to be very careful. You want to be very, very careful in the way you approach the questions. Never go into, I don't want to mention names, but yesterday I was talking to somebody and the person was like, oh, USMLE Step 2 CK is more difficult than MCQ1. I was like, really? And we looked at the percentage pass among IMGs in USMLE Step 2 CK and looked at percentage pass among IMGs in MCQE1. USMLE Step 2 CK percentage pass among IMGs about 86%. MCQ1 percentage pass among IMG first-time exam takers is 56%. And I was like, you know what? The things we discuss, they may sound superly simple. It's because of the way we take our time to break it down. You know, it is because of the way we take our time to break it down. But please, one thing you want to be very careful about is don't rush when you have to answer questions. Take your time. Because when we took our time to review overt hypothyroidism and review menopausal transition, we looked at it in relation to FSH levels, and then we know what all these things stand for. Doctors, please, take your time. I like what Dr. Maria says. She says what? Yes, doctor, this is helping me to learn and not stressing out. Thank you. You're a blessing to us. Yes, doctor, that is what we are here for. We've made a commitment. Unless, otherwise stated, we'll make sure that we keep doing these sessions so we can help everybody. And so ask yourself, if free sessions are bringing you this, what about if you get into the MedCognito program itself? Okay, next question. I'm really excited about, what if you take your time to review things step by step, what it does for you. So doctors, don't just go and pick a textbook and say, oh, I've finished menopause. No. For the medical council to put menopause as a whole objective, that means there are things you need to know, right? Okay, let's go on. So a 41-year-old woman with amenorrhea for 10 months presents with no significant symptoms. She denies hot flashes of vaginal dryness. And her laboratory results show FSH is 18, which is elevated. TSH is 2.0, which is normal. Estradiol is 40, which is low normal. Okay? And then prolactin is 14 nanogram per mole. What's the most likely explanation? A, functional hypothalamic amenorrhea. B, early menopausal transition. C, primary ovarian insufficiency. D, non-classical congenital adrenal hyperplasia. And E, luteal phase defect. So we have a lot of doctors going for B. And the answer is B. The elevated FSH, low, almost low normal. So it means like the person is on the way, right? And estradiol and irregular cycles are consistent with early menopausal transition. And this diagnosis is common in women aged 40 to 45. So why are the other options wrong? Functional hypothalamic amenorrhea would present with low FSH and estradiol, typically due to stress, all right? Typically due to stress, weight loss, or excessive exercise. And then primary ovarian insufficiency requires significantly elevated FSH and low estradiol, which are not present in this particular case. And what about non-classical congenital adrenal hyperplasia? Usually it presents with hyperandrogenism, like hirsutism, acne, which is also absent in this particular case. Okay? And then what about luteal phase defect? It is characterized by regular cycles with shortened luteal phases and low progesterone, not amenorrhea. So this patient has early menopausal transition. So Dr. Sunday Odia is asking, what about a 12-month period? Doc, this patient is not menopausal yet. The patient is, transitioning. That is, perimenopause. So we can say peri-early menopause, right? Peri-early menopause. This patient is not menopausal yet. Okay. So, doctors, please, did that make sense? Did that the questions we did they make sense? Because we are now going to do a stepwise breakdown of suspected menopause in patients below 40 years. Because this is a place a lot of people trip over. A lot of candidates trip over. Don't just go saying, oh, this objective is easy. No. There are some nuances there which you need to master. Doctors, please, can we move on? All right. We'll move on. Let's go. Please, while we do this, please like and subscribe to our YouTube channel. Subscribe, doctors. Subscribe, and let's go. Subscribe to the YouTube channel. Let's go. Okay, please. subscribe, and let's go. We are at 1,720 people. Please, let's move it to 1,750 people by the end of this webinar. Okay? Because we have more than 150 people on the class right now. All of you, please go and subscribe. Go and subscribe right now before we continue. Subscribe. Go and subscribe to the YouTube channel, MedCognito YouTube channel. Go and subscribe. Then let's go. All right? So let's do a step-down breakdown, step-up or stepwise breakdown of suspected menopause in women below 40 years. And you know, whenever I put this guy here, that means this is something you need to really, really pay attention to. Don't get afraid. I just put this here. After that, I have another step, you know, which even breaks it down further. Don't be tricked in the exam. Don't be tricked. When you are dealing with cases of menopause, first, ask yourself. So let's start with step 1. Is the patient over 40 years? If the patient is over 40 years, the next question you have to ask yourself in the MCQ, like in the case you are dealing with, is the question telling me that the patient has irregular periods, or the patient has a negative pregnancy test, and the patient has developed some hot flashes, right? So that's the first step. Look at the age. Is it over 40 years? If patient is over 40 years, irregular periods, negative pregnancy test, or hot flashes. Now the next thing is go to step 2. And this is how you are thinking in the exam, right? This is how you are thinking in the exam. Go to step 2. Or Dr. Ifran says, subscribe. Beautiful. Please, all of you, subscribe. Dr. Nori says, skin in the house. Focus on class. Sure, I'm focusing on the class. So, first, is the patient over 40 years? Because if the patient is not over 40 years, you are thinking about primary ovarian insufficiency, right? Less than 40, amenorrhea, you're thinking about possible primary ovarian insufficiency. So the first thing you have to know is what am I being told about the patient's age in the question stem? 40 years and above. If the patient is 40 years and above, I tell myself, okay, patient is 40 years and above. Now the next question I have to ask myself before I choose my option is she over 45? If she's over 45, then move to step 3, which is, has she missed her period for more than 12 months? So somebody who is over 45 years, who has missed her period for more than 12 months, that patient has menopause. I don't need to worry myself again. So first question, is the patient over 45 years? Next question, is the patient over 40 years? If patient is over 40 years, does the patient have irregular periods, negative pregnancy test, and hot flashes? If that is the case, then I have to look at the next point. That age of the patient, is it more than 45 years? If the patient is more than 45 years and has missed the period for more than 12 months, that patient is menopausal. Done. Game over. I'm done. Right? However, if the patient, so back to step 2, if the patient is 40 to 45 years, 40 to 45 years, if the patient is 40 to 45 years, then you want to do blood tests. And the blood tests you need to master for this exam are TSH, prolactin, and FSH. So when you are dealing with menopause in patients who are between 40 to 45 years, the blood tests you need to memorize are 3: TSH, prolactin, FSH. Let me go it again. TSH, FSH, prolactin. Right? If TSH and prolactin are normal in a patient who is between 40 to 45 years, then think about early menopause. However, if TSH and prolactin are abnormal, then that means that there may be another problem which is causing the patient's menopausal issues. Then there may be another problem which is causing the patient's menopausal issues. Okay? So, first, ask yourself, is the patient above 40 years? If the patient is less than 40 years, think about primary ovarian insufficiency. Now, Is the patient more than 45 years? If the patient is more than 45 years and has not had menses for the past 12 months, no menses for the past 12 months, then this patient is menopausal. Okay? Now, if the patient is more than 45 years and is having, irregular menses, then think about menopausal transition. Okay? Now, if the patient is between 40 and 45 years, then you've got to do these blood tests: TSH, prolactin, and FSH levels. If TSH and prolactin are normal, then think about early menopause, where the patient will have irregular periods, hot flashes, and other problems. However, if TSH and prolactin are abnormal, then that means that what is contributing to that patient's symptoms is more of thyroid disease and prolactin issues. Now, I know some of you may say, Dr. Brony, I'm confused. So let me take it to the next level and let me break it down even further. Some people say, yes, Dr. Bironke says we can hear MedCognito babies. Yes, my daughter just came here. After this, I have to go and spend some time with her. Right? So please, there's no need for you to be confused about this. I'm going to take it to the next level and explain it further. Now, step one, if you are in the MCQ, step one, what is the age of the patient? If the patient is less than 40 years, start thinking about primary ovarian insufficiency, right? Look for symptoms like irregular menstrual cycle, negative pregnancy test, and hot flashes. If this is the situation, move to step two. Is the patient over 45 years? If the patient is over 45 years and has not had menses for the past 12 months, it is clinical menopause. If the patient is 40 to 45 years, then that is when you want to start doing investigations. So, in which patients with menstrual issues, irregularities, will you want to do labs? It is either when they are below 40 or between 40 and 45. That's all that I'm trying to say. And what are the labs that you want to do? The labs you want to do are TSH, FSH, and prolactin. Just 3 labs. So in your exam, watch for those labs, right? Now, if the patient is over 45 years and has not had a menses and no periods, then make a diagnosis of clinical menopause. The patient is about 45 years and is having irregular menses, then think about menopausal transition, right? Menopause is not yet complete, but the patient will get there eventually. Step 4, if the patient is between 40 and 45 years, then the labs I told you to do are just 3 of them, just 3. TSH, prolactin, and FSH. TSH is to assess for thyroid function. You want to make sure this patient who is between 40 and 45 years, is there something else causing her abnormal menses apart from the fact that it is early menopause? So you do your TSH, you do your prolactin, you do your FSH. If TSH, prolactin, and FSH are all normal, then you can say that this patient is developing early menopause. However, if TSH is abnormal or prolactin is abnormal, then there may be something else beyond what the patient is experiencing. Doctors, please, is it clear? I want to make sure. Is it clear? I don't want anyone to be confused. Is it clear? Is it clear? Is it clear? I want your feedback. Please type. It's clear or it's not clear. If it's not clear, I'll go back. If it's clear, I'll proceed. Is it clear or it's not clear? Please, I want 100 yes, because I have 133 people on this thing right now. I want to see everybody. Is it clear? Is it clear? So now you know the labs you need to do: TSH, prolactin, FSH in a patient between 40 and 45 years. If all these labs, especially TSH and prolactin, are normal, then think about the beginnings of early menopause. Beautiful. Doctors, thank you very much. Thank you for the word so sweet. Everybody is saying yes, 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 yes. Thank you, thank you, thank you, thank you, thank you. I've achieved my purpose today, because this is a place a lot of candidates trip. A lot of candidates trip. So what are the critical takeaways? If the patient is over 45 years, based on history, no periods for the past 12 months, the patient has clinical menopause. If the patient is between 40, I'm just repeating what I've said, right? Just to make sure it's drummed into your head. The patient is between 40 and 45 years. The patient needs tests to confirm to rule out other conditions. And the tests are TSH, FSH, and prolactin levels. Look for important symptoms like irregular periods, hot flashes, and no pregnancy, which is negative pregnancy tests. Only do tests for patients who are between 40 to 45 years or below 40 years, where you are thinking about primary ovarian insufficiency. Now, what does Choosing Wisely Canada say? If you've not been reading Choosing Wisely Canada, now what for you? Oh, I beg you, please. For those in MedCognito, we have already done, if you go into your mock portal, you have 210 questions based on the Choosing Wisely concepts in your mock portal. Please take your time and do them. We set the questions to cover everything. And then if you also want to do, a live mock exams on Choosing Wisely as well, you can send an email to our administrator and he will sort you out. But listen to what Choosing Wisely Canada says. And someone may say, what is Choosing Wisely? Choosing Wisely is one of the links the Medical Council wants you to use to prepare for your MCCQE1 exam. It's the word itself, choosing wisely, right? So it helps you, okay, if I'm presented with this, what do I do? So what does Choosing Wisely say about menopause? It says this: don't routinely order hormone levels, including estradiol, progesterone, FSH, and luteinizing hormone in postmenopausal women or after hysterectomy, either to diagnose menopause or manage hormone therapy. This is what we've been saying the whole day. This is what we've been saying the whole day, doctors. The frequency and severity of menopausal symptoms do not correlate to the levels of either follicle-stimulating hormone or serum estradiol. Reproductive estrogen levels are typically much higher than required to reduce symptoms. Management with hormone therapy is based on using lowest effective dose to reduce symptoms to an acceptable level. Now, relying on elevated FSH to make a diagnosis may result in women being denied effective therapy for disruptive symptoms. Use of an unreliable test may in this way contribute to less than optimal care. Using blood levels to adjust hormone therapy may result in higher doses of hormone therapy than are needed to reduce and manage symptoms. In other words, Choosing Wisely is saying that if you are managing a patient on hormone therapy, or like with hormone replacement therapy in menopause, there's no need to be checking FSH and estradiol levels. Rather, you want to manage the patient based on the patient's symptoms. That's number one. Number two, if a patient becomes menopausal, there's no need for you to be checking their hormone levels again. Doctors, Choosing Wisely agrees with everything that we have been studying today. So now, before you go home or before you switch off, what are our 12 key take-home points? What are our 12 key take-home points today? Doctors, please, have you enjoyed the class today? I want to know, have you enjoyed the class? I really want to know, have you enjoyed the class? Did the class make sense? I'm going to give you 12 points. And this is how our med bullets look like, right? So I'm going to give you med bullets for menopause. Med bullets for menopause. Let's go. Med bullets for menopause. Number one, you've got to know the definition of menopause. It is the permanent cessation of menstruation after 12 months of amenorrhea, not caused by other conditions. So that's the first med bullet you need to know for menopause. Doctors, don't forget to take a screenshot of the notes you took. I really want to see. Number two, second med bullet. The median age for natural menopause is 51.4 years. Okay? Then the natural age or the median age for natural menopause is 51.4. Third point. What are the symptoms I need to watch out for? Irregular menses, hot flashes, negative pregnancy tests. These are the things I need to watch out for. Fourth point. Key phrases to master once and for all. Clinical menopause. Periods stop for more than 12 months, more common in patients more than 45 years. Clinical menopause. Number 2, menopausal transition or perimenopause. In that case, they have irregular cycles and symptoms before full menopause comes in. Next expression I need to learn, early menopause. It is menopause between 40 and 45 years. Next one, primary ovarian insufficiency is menopause before 40 years with associated health risks like cardiovascular risk, like bone health risks, increased risk of osteoporosis, like cognitive decline. Fourth point or fifth point, when to test and know what to test, right? Remember, if the patient is over 45 years, it's a clinical diagnosis. You don't need to do any lab. If I'm supposed to speak it in French, ce n'est pas l'abbé. Don't do any lab. I just coined my own French thing. Ce n'est pas l'abbé. Don't do any labs, right? If the patient is 40 to 45 years, then you want to check the hormones. And what are the 3 hormones you need to check for? TSH, prolactin, follicle stimulating hormone. 3 things, right? 3 things. Next one, sit point. Sit point. You guys are causing me to see, to speak French. Oh, I think the French people are now giving me the actual thing. It says, ce n'est pas la peine. Okay, good. Next one, interpreting lab results. If FSH is elevated and TSH is normal and prolactin is normal, likely the patient has early menopause. However, if the patient rather has abnormal TSH and abnormal prolactin, then please go further and do some further investigation into that, because the patient may have thyroid disease and hyperprolactinemia. Okay. Point 7. We've already talked about it. 12 months of no menses in women more than 45 years. Point 8. What are the health risks? Saying it again. Cardiovascular risk increased because of the loss of the effects of estrogen. Number 2, there's accelerated bone loss leading to osteoporosis. Number 3, there are cognitive concerns. Point 9, clinical management. Women who are aged 40 to 45 years with irregular periods and hot flashes require hormone testing to confirm menopause and to rule out other causes. Women who are more than 45 years can be diagnosed clinically without additional tests. Someone says I should show point 7 again. Let me go back. Diagnosis of clinical menopause. That's 12 months of amenorrhea in women more than 45 years. Dr. Khadija, is that okay? Good. Key point 10. If over 40, check periods and test hormones. Again, if over 45, clinical diagnosis, no test. 40 to 45, rule out thyroid and prolactin issues. Those are the 2 things you want to focus on. Choosing wisely, right? Point 11. What's the role of FSH? Elevated FSH supports the diagnosis of menopause, but is not mandatory to diagnose it. It's not mandatory to diagnose it. And point 12. More than 45 years, focus on symptoms and clinical history for diagnosis. 40 to 45 years, perform tests to exclude endocrine causes before confirming menopause. Today was fire. Today was fire. Fire for fire. So, great participation in the class today, doctors. Thank you very much. Tonight, you have an ethics class at 6:30 p.m. EST. So that means in about 3.5 hours, you have a class. If you are not in MedCognito, you can join us today. You can join right now. Easy, easy. Join us. You know, someone said after the last webinar, boy, oh boy, words fail me. By the way, you demystified scabies. And I hope today we demystified menopause as well, right? I was multitasking with questions from SQ Bank and UWorld on scabies while the class was ongoing. Now I could answer the questions on scabies confidently. Hey, Dr. Bruni, you nailed it like a bulldozer. You made me love dermatology. I'm so speechless. How do you do it? I don't know. Doctors, how do I do it? I do it because I love doing it. And I want to see you succeed. That is it. I really, really, really want to see you succeed. So, doctors, you can join us right now, even for 1 month, okay? So that you can take advantage of the psychiatry MedDrills we're doing on the 8th and the 18th of February. Because if you register for even a month right now, that means you have access to everything in MedCognito for 1 month. That is till February 26th, right? And you can attend every class between that time. You can have access to every mock in MedCognito portal, everything, for just $450. Or if you want access for 6 months, you can even decide to pay $420 every month. That is it, and you get access. Or you can just take, a one-time payment of $2,199, and that is it. Okay. So today was fire, and so if you want to join the class, I'm going to put the link in the comment section, and take advantage of it. Join us and come and study with us. So if you think that MedCognito is fire, then can you imagine what happens in the class itself? It's crazy. It's crazy. It's crazy. So if you want to do that, just send me a message right now. Remember, MedDrills will be coming on February 10th, February 18th. It is Dr. Bruni's time with you. We're going to finish psychiatry. Remember, tonight you're doing psychiatry, and then we'll top it up with 2 more days of psychiatry again in February. We want to cement your knowledge in psychiatry for this MCQ1 exam, so that no psychiatry thing can ever beat you. The doctors are sending messages. Please reach out right now. Reach out to me right now. And the notes you took, please make sure that you send me screenshots. I just want to connect and know that, look, people are appreciating what we are doing for them. Okay? People are appreciating what we are doing for them. So somebody says, how can we get the way Canada say it? Oh, just go to Choosing Wisely Canada. So just type in Choosing Wisely Canada. It's there. All right. So doctors, please. You decided that you want us to do psychiatry MedDrill in February. I'm ready for you. On February 10th, we're going to meet. On February 18th, we'll meet again. And then we'll get it going. Dr. Ifran says, Dr. Bruni, I need a 3-month course. Yes, Dr. Ifran. In fact, we just created a link for 3 months. So just reach out to me on WhatsApp right now. It's very affordable. I think it's just 1,000. Let me just check for you. For 3 months. If you want access for 3 months only, I will just I'll just get you there how much it goes for. For 3 months, it goes for just 1,350 for 3 months. For 3 months. So if you want 3 months access, just send me a WhatsApp on +1 306 891 5649 right now, and I'll send you the link so that you can join the psychiatry class. Okay. And remember that if you are a MedCognito candidate, you get the MedDrills for free. You get everything in the MedCognito portal for free. If you're not a MedCognito candidate, you'll attend the class, but you won't get the replay and everything. Okay. And for those who need the replay is in the Sprint portal for all the MedDrills we are doing. Okay. Yeah. So it says, is it that my comments are not visible to Dr. Bruni? Dr. Bruni, Dr. Oriasoti, your comments are visible. Oh, and then you were asking, why don't we do you asked the question, I think you asked the particular question. Why is estradiol not tested? Estradiol is only, an adjunct test. The test you want to focus on is FSH, prolactin, and TSH. All right? Sure. So I hope I answered your question. Okay? So doctors, if you want to register for the MedDrills only, you can scan this. But I will encourage, even take just a 1 month access. Because MedDrills is $199. That's $200. 1 month access is just $450. And you get access to everything in MedCognito. Or if you want the 6 months access, that's even more beautiful. All right? And then we can get a ball rolling. Doctors, I'm expecting your calls. I'm expecting your text. I'm expecting to see the notes you took. It's always a pleasure, to study with you. It's always a pleasure to come your way. It's always a pleasure to know that what we are doing is benefiting people. Please keep sharing the good news of MedCognito. Tell a friend to tell a friend to tell a friend. Send a WhatsApp message right now. And doctors, thank you very much for spending your afternoon with me. I really, really appreciate this. You give us the fire, and we give the fire back. So continue studying, and please remember you have a psychiatry class tonight, 6:30 p.m. EST. Let's go. And it's going to be with Dr. Nana, and you will love it. Okay, thank you very much. Have a wonderful day. Bye-bye. Bye-bye.